Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to today's guest speaker. Joining us today, we have Dr. Amit Chopra. Dr. Chopra is a psychiatrist and sleep specialist at Mass General who specializes in the treatment of mood disorders. He leads the Treatment-Resistant Depression Initiative at Mass General, which is an innovative program to expedite access to specialized care for people with difficult-to-treat major depressive disorder. In recognition of National Depression and Mental Health Screening Month, he joins us today to give a talk on updates in the management of depression. So please join me in welcoming Dr. Chopra.
Thank you, Amy. It's my pleasure to be here, and hello to all of you who are listening in. I'm a psychiatrist and a sleep specialist, as Amy has described, and my area of interest is mood disorders and sleep disorders. Depression is a broad topic, and I thought it'd be helpful to kind of, discuss some basics of depression, the challenges we see in the treatment of depression, and the newer treatments that have come up for effective treatment of depressive disorders, and some innovative approaches that we at Mass General are trying to implement to expedite care access to people who need it the most. So with that, I'll start off. I have no disclosures for this talk today. So the main objectives for today's talk are to understand the challenges that face us for optimal depression treatment. Secondly, to describe advanced treatments for management of major depression. And thirdly, to discuss innovative clinical care models for management of difficult to treat depression. So let's talk about the diagnosis of major depression. It's different than sadness. Sadness is a human emotion that we all go through, which is transient, short-lasting, and maybe in response to a trigger or a stress, and we start to feel better in a matter of some time. But for depression, the feeling of sadness stays there for weeks in a row. So the main criteria for depression diagnosis is feelings of sadness, tearfulness, or hopelessness, loss of interest or pleasure in usual activities. And these are the two key criteria, and we need to have at least one of them to be able to diagnose major depression. Then there are additional symptoms that come along with depression, including sleep disturbances. That may include having insomnia or sleeping too much, changes in energy levels with feeling tired or having lack of energy, changes in appetite where people can eat less or more, and there may be accompanying changes in their weight, either weight gain or weight loss. The thinking can be slowed and the movements can be slowed. And in some cases, when people have agitated depression, people can be noticed to be more restless as compared to being slow. There almost always is trouble with thinking, concentration, and making decisions. And in terms of the cognitive symptoms of depression, there are feelings of worthlessness, guilt, or self-blame. And on the dangerous side, people can have thoughts of death, dying, or suicide. So for us to make a diagnosis of depression, we need to have 5 of these symptoms. That includes either persistent feeling of sadness or loss of interest in their daily activities when people are feeling sad, and 4 of these additional symptoms. So you can see there can be hundreds of combinations that people can present with when they're depressed. So when we see depression in clinics, no depression looks alike, because people can have their own set of symptoms that can accompany sadness or lack of interest in the daily activities. And sometimes that can make it a little harder to diagnose as well, because some of the other symptoms might be caused due to some ongoing medical problems or some other factors. And there are no diagnostic tests to confirm depression. It is a clinical diagnosis that we need to kind of consider each time we see patients. However, we can do some lab tests to rule out any medical problems that we are suspecting at the time. Now, importantly, not only these symptoms are happening, these symptoms are causing clinically significant distress or impairment in a person's social, occupational, or other important areas of functioning. And as I mentioned earlier, the symptoms can be led by some other issues or medical problems, and the episode of depression is not attributable to the physiological effect of substance use or to any medical condition that may be causing the depressive symptoms. For example, people may have thyroid problems where they start to have low energy, changes in their appetite, and lack of interest in the daily activities. But that's a totally correctable condition if we identify the thyroid deficiency and treat it. And so is depression. Depression is completely treatable as well, but we need to identify the right cause in order to achieve the optimal outcomes. Can you move to the next slide, please? So what are the risk factors or causes that can lead to depression? There's no single cause that has been identified yet for depression. It generally is the combination of causes and risk factors, such as genetics. If people have a family history of depression, the risk of having depression in the offspring is at least 2 to 3 times higher than general population. And it could be up to 30% to 40% risk of having depression if parents have depression in the family or somebody else in the family has depression. And there's been more depression reported in females as compared to males. And there are some personality traits that could predispose people to have symptoms of depression, where people are more self-critical of themselves, they have low self-esteem. Trauma is a big trigger for depression. And sometimes we see that not uncommonly that trauma precedes the depression, and it can make the depression treatment somewhat difficult. Life stressors, and these could include multiple situations like job loss, financial issues, relationship problems, loss of somebody who's a loved one, major illnesses medically, such as diabetes, heart problems, neurological illnesses such as Parkinson's disease. All of them can be accompanied by high rates of depression. And then socioeconomic vulnerability can be a risk factor too. Can you please move to the next slide? So depression can happen at any age, and based on different ages, we can define it as childhood onset, which happens by age 12, adolescent onset, which happens between ages 12 to 17, early adult onset between ages 18 and 44, and then late adult onset age after 60. And we do see that, when there's a strong family history, we notice that people may have a childhood onset of depression, and this may take a more recurrent course than other depressive episodes that happen later in life. And when we talk about the course of the depression, it follows a recurrent course generally. When a person has the first episode of depression, the chances of having the second episode of depression is 50 to 60%. But once you have the second episode, the chances of having the third episode is like 80 to 90%. And that's why a long-term treatment is advised for people who have 2 or more depression episodes as compared to somebody with 1 episode of depression. And we'll talk about the management in more detail in the coming slides. Next slide, please. So how common is major depression? An estimated 21 million adults in US have at least had one major depressive episode in the last year, and this number represents 8.4% of all US adults. The prevalence of a major depressive episode is higher among adult females, as we talked about earlier, as compared to males. And the prevalence of major depressive episodes is highest among individuals aged 18 to 25, up to 17%. Can you move to the next slide, please? So what is the impact when we are seeing this much of incidence and prevalence of depression? One of the leading causes of disability worldwide in both men and women is depression now. And it can lead to impaired functioning, job loss, impaired academic functioning, and poor quality of life. Significant personal health care costs are related with depression onset and progression. And more importantly, there's an increased risk of self-harm or suicide, which depression tends to be a major cause. There are around 1 million suicides across the world each year, and depression tends to play an important role in causing the suicidality and tendency for self-harm in people who eventually commit suicide. Can you please move to the next slide? So according to WHO or World Health Organization report, there are at least 75% of people across the globe who suffer from major depression and do not receive adequate treatment. And the 3 main barriers that lead to this kind of number, that 2/3 of the patients or more are not seeking treatment. One is the stigma, the second is the access to mental health care, and third is compliance with the treatment. Next slide, please. The stigma results from fear or lack of understanding or misconceptions about mental illness, and it can be propelled by personal kind of impression about the depression that people have. They have negative views, including that the mental illness is a sign of weakness, and seeking help is a sign of weakness as well. And then there's a public stigma where there can be a public image of negative or discriminatory attitudes towards people who have mental illness. And then there's institutional stigma, which is systemic in nature, and it includes government and private organizational policies that intentionally or inadvertently restrict opportunities for persons with mental health illnesses that may be manifested as less funding for mental illness research, fewer mental health services as compared to other healthcare services. And fortunately, I think all of this is changing in the right direction, but the stigma still persists. Next slide, please. Now, let's talk about access to care. So this is some data from Mental Health America website, and it appears that more than 60% of the youths who have the highest rates of depression, up to 17%, receive no mental health treatment, which is very concerning and shocking. And the states in the US with highest rates of access to mental health care report that only 33% of the youth, or at least 33% of the youth, were not receiving any treatment. So even if there's a good mental health care access, in some states, a third of the youth are still not receiving the treatment. And nationwide, there's an increase in the rates of depression in adolescents and self-harm amongst adolescents. And in that situation, fewer than 33% of the adolescents with severe depression have obtained consistent mental health care. So this is something that is very concerning, and that makes us think, how best we can provide care to the people who need it. Next slide, please. So now, if we have overcome the hurdle of stigma and access to care, then compliance can be the third issue that can come in the way of optimal treatment of depression. Approximately 1/2 of the patients who are prescribed antidepressants discontinue their treatment prematurely. And this could be related to either patient-related factors or clinician factors. With patient-related factors, the medication costs, worries about adverse effects, fears of addiction, and misconceptions about depression and the antidepressant treatment can be major factors that can compromise the compliance. In terms of clinician factors, maybe the clinicians don't spend a lot of time that they should, talking about patient education and the importance of taking these medications on a regular basis and the side effects that may come up with the treatment course, or maybe the patients are not following up in adequate time, such that the patients, stop the treatment before seeing the doctor again. And it's concerning that almost third of the patients discontinue the antidepressant therapy within the first month, which is a number that can be improved very significantly if we address the patient factors and the clinician factors that lead to non-compliance. And 44%, approximately, half of them discontinue by the third month. And we'll talk about the course of the treatment and how the initial 3 months are so important for us to obtain a response or a remission from symptoms of depression and maintain that progress going forward. Next slide, please. So how we can improve the compliance, and I think here one size doesn't fit all. The treatment plan has to be tailored to an individual patient and adjusted as needed throughout the treatment process. Individuals with depression should be encouraged to take an active role in their health, and they're active participants in formulating that treatment plan. There's a need to establish treatment goals to improve not only the depressive symptoms, but also the quality of life, so that they see a meaningful change with the treatment happening. And then the focus should be to minimize the incidence of common and serious adverse effects from medications that can lead to non-compliance with the medications or premature discontinuation of the medications. And in summary, the successful treatment really depends on the early recognition and management of depression, and very importantly, to adherence to the selected therapy and the routine monitoring. You just don't start it, you monitor it on a regular basis and tailor the treatment plan as the treatment process goes on. Next slide, please. So let's talk about some conventional treatments first. So the first line treatments for depression are antidepressants that come in several categories that we can think about and prescribe based on their efficacy and how well they'll kind of work with the patient's clinical history and medical issues. And then there's talk therapy or psychotherapy. So what is the threshold to start the antidepressants? So there's some data according to guidelines, and it's kind of thought that the milder version of depression would basically benefit more from non-pharmacological interventions, including lifestyle modifications, stress management, exercise, increased socialization, counseling, therapy, and the antidepressants should be ideally reserved for moderate to severe depression, where symptoms are more severe, they're more impairing a person's day-to-day functioning and quality of life. Now, in terms of antidepressants, we have several categories. The first line treatments are selective serotonin reuptake inhibitors, or SSRIs, and then there are serotonin and norepinephrine reuptake inhibitors, SNRIs, and the atypical antidepressants, medications such as Wellbutrin or mirtazapine. Then there's some older categories that were in favor like 20, 30 years ago, but not used as first line or second line treatments these days. And these include tricyclic antidepressants and monoamine oxidase inhibitors, or MAOIs. I think in summary, the goal of these medications is to bring upon some neurotransmitter changes in the brain and increase the concentrations of neurotransmitters such as serotonin or norepinephrine by one mechanism or another. And psychotherapies have a very significant place in treatment of depression. As I say, it may be the first line intervention for milder depression, and it frequently is an option that we can combine with medications for optimal treatment outcomes. There are different types of psychotherapies that can be applied, but cognitive behavioral therapy, where therapist works with people with depression to identify unhelpful thoughts, unhelpful behaviors, to bring a change in terms of the coping mechanisms and bring a change in overall outcomes of depression. It is more of a time-limited treatment. 12 to 16 sessions are generally needed and has the most evidence base in successful treatment of depression. Next slide, please. And depression can be treated in different patient populations, and the safety of antidepressants in pregnancy and breastfeeding. I know this is a very sensitive topic, and I think the way to proceed here is to kind of to assess the benefits and the risks of each situation, whether we treat the depression with antidepressants or not, because there are some risks involved with use of antidepressants, but I think those risks are very minor. And if you compare it with the risks that come along with a normal pregnancy and a risk that would come along with pregnancy and untreated depression, I think the risks that come along with antidepressants for depression treatment during pregnancy are very, very minor. And overall, these medications are safe. And there are some particular medications like SSRIs, such as sertraline, that is considered as first choice during pregnancy. In elderly, I think there's a myth that the elderly depression, may not be treated as well. That's completely a myth. We can achieve optimal outcomes to the point that we can successfully treat depression. But the thing is that we have to, be a little careful about, how we dose the antidepressants. We usually start with half the dose and gradually titrate the dose up to a maximum dose. And the responses can be very similar to how we see the responses in adult population of depression. And we can use most all categories of depression treatments, such as antidepressants, but we have to be a little careful with some of the antidepressant categories, some of the older categories of antidepressants, such as tricyclics or monoamine oxidase inhibitors. They are probably not the first choice. And in general, they are not the first choice in any depression treatment. The first choices are SSRIs that have the safest, profile in terms of adverse effects and most tolerability, so as to speak. Not that they are without side effects, and we'll talk about that in a minute. And for children and adolescents, there are two medications that have been approved by FDA for treatment of major depression. These include fluoxetine and escitalopram. Now, there is a black box warning for increased suicidality in youth when we are treating depression in people who are 25 or below in terms of their age. We have to be careful about the risk of suicidality. In some people, there may be increased thoughts, but may not be actual attempts, and we have to be, very careful in terms of counseling the patients and their parents about this particular complication that could happen and how to seek help on an urgent basis and how to monitor this on an ongoing basis. And on the whole, there's a black box, not the black box warning, but the warning that these medications can cause suicidal ideations in patients with depression, even if it is patients who are adults. But if you look at the larger literature, I think that the antidepressant medications have a protective effect in terms of having the suicidal ideations or acting on the suicidal ideations, both in adults and elderly people. Next slide, please. So let's talk about the treatment process. What does it entail once you have made a diagnosis of depression and you're talking to somebody as to what option would be good, and we get to select the antidepressant treatment based on the symptom severity and their preference for treatment. So usually we start at the low dose. The lowest effective dose is what we go for, and titrate it every 2 to 4 weeks. It takes 2 to 4 weeks to manifest antidepressant effects, and that could be a painful time to wait. And during that time, we are kind of looking more into side effects than effects. And I must say that the antidepressants start to work, in the brain right away, but the effects are manifest, in a couple of weeks because of how the neurotransmitter changes in the brain. It takes some time to do that. And this can be a bit of a drawback, for some people where we need a lot of urgent response due to the severity of symptoms. And that's where the field has moved to faster acting antidepressants. And we'll talk about those, in the coming slides. So back to antidepressants, a third of the patients would achieve remission with the first antidepressant trial. That's not very, very promising. When I say remission, it means complete improvement in the depression symptoms or minimal symptoms if they're present at all. And there's another term called response. That's something we call when we see more than 50% reduction in the depression symptoms as compared to the baseline. So those are the two terms we go with. Has the person gone into remission where there's a complete, improvement in their symptoms altogether, or very minimal symptoms if at all, or have they gotten into response where they have achieved 50% or more improvement in their symptoms? And this is something we can assess by using some rating scales that people with depression can use, and they're commonly used in clinical settings, both in primary care offices and psychiatry visits. But that doesn't mean like when the first trial has only helped a third of the patient that we lose hope. There's hope, and by the end of 4 trials of medications, either alone or in combination, a majority of the patients would achieve remission. Like 2/3 will achieve remission, meaning they're completely free of depression symptoms after the treatments that have been tried. But there's still a third of the patient who are needing help, and we'll talk about that with what that means and what options can be offered to them. And they fall into the category of treatment-resistant depression, so to speak, which is another topic that we'll talk in more detail. in the coming slides. So it's important to understand the antidepressant treatment phases because, as we had talked about earlier, how majority of the people would prematurely discontinue their antidepressant due to a range of factors. So the antidepressant treatment phases include acute treatment, continuation treatment, and maintenance treatment. So the acute treatment is to kind of resolve the acute episode, and this goes on for 8 to 12 weeks. Our hope is that we start the antidepressant within 8 to 12 weeks, we are able to contain the depression symptoms and bring the person into remission. Now, once the person is in remission, we don't stop the antidepressant, and that's why there's a continuation phase. And by that, I mean, for another 6 to 9 months, we will continue with that dose that got the person better. And there's a strong rationale to do it because if you stop the antidepressant after 3 months, as compared to continuing it for 9 months, the risk of relapse of illness is significantly higher. I think 65% of the people can relapse, if they stop the antidepressant 3 months after their successful treatment, as compared to less than 25% who continue with the treatment for another 6 to 9 months. And then the maintenance treatment is not for everybody, as we talked about the fact earlier that the depression episodes get more frequent or recurrent in a way if somebody has had more episodes to begin with. So maintenance is needed for people who have 2 or more episodes of depression. And I think the treatment duration can vary. If we go with Canadian or UK guidelines for maintenance treatment of depression, they recommend at least 2 more years of treatment if somebody has had 2 or more episodes of depression. But this can vary from a person to person, and sometimes the treatment duration can be longer. Now, there's a concept that we need to talk about, that after a while the medications can stop working, and some people call it as a poop out of medications, SSRI poop out, which can happen in almost 25% of the people who are taking it on longer term. And we don't exactly know at this point as to who those people are in terms of risk factors, what would lead to those outcomes in those patients. But I think on the other side, I think 75% of the people maintain the efficacy and they can stay free of depression. So that's an area of research that needs to explore those risk factors as to which people would develop kind of a tolerance to the effects of these medications in the long term. But it's generally recommended if people have 2 or more severe episodes of depression to continue it for at least 2 or more years and not stop the medication prematurely. Now let's talk about the safety of the antidepressants. These are generally safe medications with no addiction potential. I think that's for sure, that there's no addiction problems using antidepressant medications, but they're not devoid of side effects. They have their own set of side effects. Most of them can be time limited, and they can get better with taking the medication. But some of them can be bothersome and can persist and may not go away. And there are strategies to kind of work through those situations if they happen. So the common side effects that happen when people take antidepressants, such as SSRIs, are GI symptoms: nausea, vomiting, constipation, diarrhea, and sleep disturbance, either insomnia or hypersomnia. Weight gain doesn't happen right away, but it can happen as people move along with treatment. And sometimes people can have sweating with certain antidepressants, and sexual dysfunction can be an issue that can be a significant cause of concern, and it can lead to discontinuation of medications. So early on, it is more the GI side effects that we need to worry about. And Basically, these side effects can be averted in some way that we start with a low dose. We have people take the medication with food and, go up on the dosage, ever so slightly, if people are more sensitive to the optimal dose. Sleep disturbances can be, avoided if somebody is having a sedation side effect with the medication. We can use that medication towards evening time. If the insomnia is being caused, we can have them take earlier in the day, and there are medications that we can switch to if the sleep disturbances are not getting better. There are some good choices with weight gain issues. In terms of antidepressant treatment, there's a medication called Wellbutrin that is commonly used in this situation. Then sexual dysfunction is quite prevalent. Almost 30 to 50% of the people can complain of sexual problems, but it is important to know that these problems may exist even before the depression is treatment has started. Um, Between 20 to 50% of the people with major depressive episode would have sexual problems, including lack of libido or sexual functioning. So it's important to get a baseline so that we are not blindsided by the medication causing this problem kind of on its own. And it's important to look at some other factors, lifestyle factors, smoking, alcohol, some medical issues, high blood pressure, diabetes, and then some of the medications that a person may be using, which are not specifically um, for depression treatment, but they may cause some sexual dysfunction. Next slide, please. So, as we talked about, like a third of the patients get into response remission, right away with the first treatment, and almost 50% of people get a response with the first treatment. So that's more encouraging than the remission with the first antidepressant treatment. So what are the predictors of these responses? Like who tends to get a positive response as compared to who tends to get a negative response? So there are some factors, that have been studied. Race, gender, being Caucasian or female, being employed, having more years of education and income might be positive predictors of response. And I think some of these factors may lead to more compliance with the medications too, that can lead to a better outcome. And the negative predictors, like the longer the depression has not been treated, or the more chronic it is, the harder it can get to be treated. So that's why we talk about early intervention, not waiting too long for the depression episode to get worse before we start the treatment. Uh, then increased number of psychiatric disorders that come with depression. Depression usually comes with a bit of a comorbidity always, and there can be a lot of comorbidity in some people, and that can make the treatment response difficult to achieve. And the common comorbid psychiatric disorders are anxiety disorders that may include generalized anxiety, panic disorder, social phobia, and drug abuse, like problems with alcohol or recreational substance use. Then there's a greater degree of general medical comorbidity. If that is there, that can predict not a very robust response, because the illness itself may have effects that can mimic depression or worsen depression, such as people with Parkinson's, if they are having sleep problems, if they're having fatigue, the depression treatment may not be able to treat all of those symptoms on its own, and we need to have a robust treatment plan where there are multimodal interventions looking at different aspects of the patient's presentation and addressing neurological issues, sleep issues, um, psychiatric issues for best response. And then if people have lower levels of functioning and lower quality of life at baseline, it may be a hard task to kind of get a good response with the medications. Next slide, please. So what do we do if we notice that a person is not having adequate response to the medication? And this is not an uncommon scenario at all. And there are a lot of strategies that can be used to address this issue. One is to optimize the dose of antidepressant. Sometimes we may not be utilizing the optimal dose, and the medication may be discontinued prematurely, thinking that it was an optimal trial. And we call this as pseudo resistance when a medication has not been used at optimal dose and for an optimal amount of time. And when I say what is an optimal dose, like for an SSRI, like Lexapro, we need to, or escitalopram, we need to use that for at least 4 to 6 weeks, and sometimes even longer, and at a dose of 10 to 20 milligrams. So if somebody has tried only 5 milligrams for 3 weeks, that's not optimal dose or optimal, treatment duration. Now, if we have tried an optimal dose, we have a couple of options, as to what to do next. If it has been tried for optimal duration as well, we can switch to a different antidepressant, either in the same class of medications or a different class of medications, or we can combine two antidepressants. And how do we make that choice? Or how do you talk to your doctor about that as to what should we do? That is determined by what kind of response you had with the first antidepressant that you were on, and if there was 25% or more improvement, meaning there was a partial response but we couldn't build a full response or remission, we can think about adding an antidepressant, and it can also be a consideration if one medication is helping with one set of symptoms like low mood, but the energy is still lacking and the concentration is still not there. So in that case, if somebody's on an SSRI, like sertraline, we can add Wellbutrin to kind of augment the function of the medication and kind of target the symptoms that are remaining to be treated. Now, there are other strategies too. Now we can use non-antidepressant medications in combination with antidepressants, and that's called augmentation. And there are some medications in this line of intervention that are used quite frequently. So the ones that are based on most evidence are adding lithium to the antidepressants, adding thyroid supplement, adding stimulants, and adding atypical antipsychotics. And we can combine psychotherapy with medications, and this can lead to significantly higher rates of improvement of depressive symptoms, enhanced quality of life, and better treatment compliance. So I think in the interest of time, we can maybe go along the slides a little bit more quickly so that we can get to answer some questions. Next slide, please. So what is treatment-resistant depression? As I mentioned before, it is failure to respond to more adequate antidepressant trials. And approximately 1 in 5 people with major depression have a treatment-resistant course. And this is associated with increased depression severity, functional impairment, like job loss or impairment of their daily functioning, and increased risk of suicidality. Next slide. So what do we do in this situation? We ensure compliance with medications, make sure that people are taking their meds. We revisit the diagnosis, whether or not we're treating the right condition. And here it's important to rule out bipolar spectrum disorders or bipolar disorder, because the major depressive episode of bipolar disorder looks like major depression. and there's no way to distinguish that, but we have to look into a history of hypomanic or a manic episode where people have more energy, they're more elevated in their mood, they need less sleep, they have more activity going on, they have more impulsive actions that are out of character for them. And if that's happening in a circumscribed period, and they seem to be significant enough to be concerning either to the person or their family, then we think about having a bipolar spectrum disorder. And additionally, we look at, what is coming along with depression that we're not identifying or treating. Could be a range of psychiatric disorders, anxiety disorders, PTSD, OCD, medical issues like chronic pain, fibromyalgia, sleep disorders like insomnia, sleep apnea, substance use disorders, um, like alcohol use disorders or cannabis use or any other recreational drug use disorders. And we have to treat the depression and comorbidities to achieve the optimal outcomes. Um, uh, Next slide, please. So there's some new medication treatments that are faster acting, and they have a different way of action. One is dextromethorphan and bupropion combination is called Auvelity. That's been recently approved by the FDA. It's the combination of Wellbutrin or the bupropion and dextromethorphan. It works on the glutamate receptors, and it can be associated with earlier response within the first 2 weeks. Similarly, esketamine or ketamine has been FDA approved, and it also works on the glutamate receptors. The rapid effects are of uh, quite a bit of importance for this medication, and people can see effects within a couple of days of getting the treatment, although the effects may not be long lasting. So this has to be timed every couple of times a week, or maybe a little less as we move along with the treatment, moving into 4 weeks or more of treatment duration. We do it once per week. In the first 4 weeks, we do the ketamine treatments um, twice a week, and this is something that needs to be supervised, and people have to be in a treatment facility for a period of 2 hours because there can be changes in blood pressure, pulse, or episodes of dissociation that need to be monitored. Additionally, brexanolone or zuranolone, they've been indicated for postpartum depression only. They have unique mode of action. They work on the GABA receptors in the brain, and the brexanolone is given IV. That's one of the IV medications that we prescribe for postpartum depression, and zuranolone is the oral version of the medication. It's slightly different from brexanolone, but it has equally good effects. And their rationale is different in terms of the duration of treatment. For zuranolone, it's prescribed only for 2 weeks, and the effects can be sustained for up to a few months. Next slide, please. And then there are brain stimulation treatments that include transient magnetic stimulation, ECT, and vagus nerve stimulation. In the interest of time, I think we have 10 minutes left, so we can take some questions, or I can go a little bit more and discuss a little bit about these brain stimulation treatments.
I think we have a few more minutes if you want to
Okay.
continue.
Great. Yeah. So brain stimulation treatments have a special place in the field of psychiatry and treatment of depression. And as I say, there'll be 1/3 of the patients who have not remitted in terms of depression, even after trying 4 or more trials of medication. And I think at that point, we need to start thinking about the next steps as to what would be an effective option. And that's where we need to think about either TMS, ECT, or VNS. So TMS has been approved by the FDA for treatment of depression since 2008, and the technology has evolved significantly. So what it involves is it uses the principle of electromagnetic induction, where there's a magnet applied to a part of the brain, and there's a rapidly changing magnetic field, and that would induce a small electric field or electric current in a focal part of the brain, and that has downstream effects in terms of improving depression. And this is a treatment that is done in outpatient setting, and it doesn't need any anesthesia. And the treatment involves administration of these TMS sessions once per day for a period of 5 days a week in up to 32 to 36 treatments. They're generally safe. The side effects are mild in terms of headaches or pain to the area where the stimulation is applied. One risk can be seizures, but we carefully review the history and make sure that people who are high risk of seizures don't get this treatment. And it can be very effective for patients with depression, and it can be comparable to ECT, which is the gold standard treatment for difficulty depression. And especially for people who have severe depression, but it's not associated with any psychotic symptoms, meaning paranoia or delusions or hallucinations, or people who are not actively suicidal. And that's where the ECT comes into play. And it is a trusted treatment with the highest efficacy of all the depression treatments. Up to 60 to 80% of the people get better with this. This treatment technique is a little bit invasive in a way that a person has to be in the hospital. They have to be anesthetized, and they have to be given a muscle relaxant, and a brief electrical current is administered to induce a seizure in the brain and the body for a period of less than 1 minute, and they're monitored in the hospital setting. And once they come out of this, they're discharged home. This is done 2-3 times a week, and up to 12 treatments for most people, where it would start to work. And sometimes people can go into maintenance phase with ECT for longer treatments. The side effects, acute side effects, are nausea, vomiting, headaches, but the concerning side effect could be memory problems, where people can have difficulty with remembering things around the time of the ECT or before and after the period of ECT. And usually this resolves, but in some people there can be a permanent gap in the memory. And there are some techniques to avoid that, the way the electrical pulse is administered, and the location, how it is administered. When you give it to both sides of the brain, it can cause more memory problems as compared to the right side of the brain, where it doesn't, or as much. And it is the most effective treatment when people are feeling acutely suicidal. For people who are not able to take care of themselves, they've stopped eating or drinking, or if they're having any psychotic symptoms. Finally, vagal nerve stimulation. Vagus nerve is one of the cranial nerves. That's the 10th cranial nerve. And what this involves is, I can show you a picture as well. Can you move down a couple of slides, please? Next slide, please. Next slide. So VNS, as you can see, there's a pulse generator that is implanted in the chest, and that is connected to an electrode that stimulates the left vagus nerve. It can be a very effective treatment, was approved by FDA in 2005. It's not a treatment that would be effective in treating acute depression, but somebody who has had acute depression and now they're at risk of having multiple episodes going forward in the future that are disabling, that can be a good intervention to consider. It is an invasive procedure, and you need a surgeon and a neurosurgeon to kind of implant this device, and then this is programmed by psychiatrists in an outpatient setting. And usually the effects are not seen in the first few months. It takes a little longer to get into effect, and that's why it's not the best treatment for acute depression. But if you go into like a year follow-up, 2-year follow-up, people who have the most resistant depression can start to feel better. Up to 30 to 50% response rates have been reported. There are some safety issues that come with this. It's a surgical procedure, so that is kind of granted that we have to consider the risk associated with anesthesia and implantation and any surgical infections. And then some people can have some hoarseness of voice by stimulation of vagus nerve, but that's usually not a reason why people would stop this treatment. It's more manageable with tweaking the parameters of stimulation. So I think with that, I think we can take a few questions. That covers it all for the interventions that we need to discuss about depression treatment. All right, so I think there's some questions in the chat.
Thank you so much. We
Sure.
have
Yeah,
a question from an audience member asking what types of questions you would ask a patient before prescribing an antidepressant medication to them. For instance, do you get a better understanding of why they are feeling depressed?
exactly. I think it is quite comprehensive as to what the triggers are, what the symptoms are, what's the level of severity, how much their quality of life is being affected, what medication trials they've done in the past, what have the side effects been, what are they most concerned about if they consider the next treatment, and what are their expectations, and any other general questions that they may have, answer those. And then, based on the history and the symptoms and the options that are available that could be effective, we come up with a next step option.
Thank you. And where can one go online to learn more about depression as well as treatment options?
Yeah, so if you scroll a few slides down, I think I have a list of self-help resources. I think we can somehow share with the people. If you can go down a few more slides. It's towards the last. It's a whole list of resources. I think NIH, is a good site to read up on what's new and what's evidence-based in terms of depression treatments. And I think there's some resources outlined here that could be helpful to people.
Thank you so much.
Sure.
Before we end today's session, do you have any final thoughts you'd like to share with the audience?
Yeah, I must say that depression can be a hard illness to treat, but it is completely treatable. The new treatments on the horizon and the advancements have been very, very encouraging. We have a lot of options now as compared to 10 years ago, and a lot of effective options. I think what we need to do better here is to kind of personalize the treatments with the people. I think that's the part that's missing at this point, but the work is going on, and maybe in the next 5 to 10 years, we'll have ways to kind of match the right treatment with the right person and to get a response early on as compared to getting into a treatment-resistant course of depression.
Thank you so much. And for everyone who joined today's session, thank you so much. Hopefully you found today's session helpful. As I mentioned, today's session is being recorded. If you're interested in viewing the recording, they'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.